Hi, this is Dr. Neurosurgery Greenberg. Today we are going to discuss acromegaly. It is the abnormally high levels of growth hormone in an adult, and more than 95% of cases are due to a benign pituitary adenoma. And at the time of diagnosis, most of them are macroadenomas. They have grown more than 1 centimeter in size. In acromegaly, the problem is not just the growth hormone, but actually its effects, which are soft tissue growth, skeletal changes, cardiomyopathy, and colon carcinoma. So you have to do the workup, the endocrinological testing, the cardiology consultation, and the colonoscopy. And for treatment, you have to go for surgery. But if any residual problem is left, you will go for medical therapy and radiation. And if you want to achieve biochemical cure, then the IGF-1 should be normal. The growth hormone level should be less than 5 nanogram per milliliter. And the growth hormone needed should be less than 1 nanogram per ml after oral glucose suppression testing. So one by one, we will look at the acromegaly. First of all, why has the growth hormone elevated? Actually, it is because of the pituitary adenoma that has led to more secretion of TSH. And when this happens in children before the closure of the epiphyseal plates of the long bones, then it leads to gigantism. But in adults, there is acromegaly, soft tissue findings are more, and hypertension can also occur. So apart from the skeletal growth deformities like increasing hand-foot size, thickened heel pad, frontal bossing, prognathism, there is cardiovascular problem as well, like hypertension and some arrhythmia, etc. Then there is glucose intolerance, peripheral nerve entrapment syndrome, and cancer risk is doubled. So once you have started the therapy of acromegaly, then you have to look which things are reversible and which are irreversible. So the bone and cartilage lesions that have formed in the soft tissue arthropathy, and they are irreversible. Okay, then similarly, if there are in the case of neuropathy, there are onion bulbs or whorls which do not regress. In cardiovascular disease, actually, instead of getting better, it deteriorates. Even after you have performed biochemical cure and the growth hormone levels are normal, still the cardiomyopathy is going to increase. Respiratory disease gets better, but this thing I told you that cardiomyopathy is not going to be reversed. The onion bulbs or whorls of neuropathy do not regress, and bone and cartilage changes are irreversible. Then you come to the thyrotropin secreting adenomas, and they will cause a raise in thyroxine, and the TSH will also be paradoxically raised. And these tumors are very adherent, they are very fibrous, and it is very difficult to perform gross total resection of thyrotropin secreting adenomas. And clinically, what you will look at is hyperthyroidism like anxiety, palpitations, heat intolerance, hyperhidrosis, weight loss. And other findings are hyperactivity, lid lag, tachycardia, dermopathy, and exophthalmos. Okay. Now, these two are present only in Graves' disease, that is hyperthyroidism due to thyroid problem. Those are exophthalmos and infiltrative dermopathy. Now, there is another classification which is a pathological classification in which you do the staining. So, if it is chromophobic, then maybe it is secreting prolactin, growth hormone, or TSH. Eosinophil will secrete TSH, prolactin, growth hormone. Again, the same ones. And basophils are only the ones which are secreting ACTH. Then tumors of the neurohypophysis and infundibulum. Actually, what happens is that if the pituitary, the posterior pituitary has a tumor, has a lesion, it is a metastatic lesion. So they are not very common. And that is all about some overview of pituitary adenomas. We will do another video on the evaluation of the pituitary tumors. And till then, thank you so much and God bless you.